Ladies and gentlemen, our webinar is going to begin. I'm Steve Love, President, CEO of the Dallas-Fort Worth Hospital Council. We really appreciate you being here today. This is going to be a wonderful educational webinar, and it's hosted in coordination with FORVIS, who is an associate member of the council and is very supportive of many of our activities. Today's topic is Rebuilding Stronger: Cost Reduction Strategies Post-Pandemic. This is probably one of the most important topics that we will be discussing post-pandemic. During the post-pandemic era, hospitals obviously are focusing on their cost, and leaders are searching for financial stability in an industry is anything but predictable. The balance between cost and delivering positive patient experience is always difficult and tenuous. For this panel, we have two FORVIS experts who are going to detail ways to take control of operating expenses and also identify strategies to help with staffing, equipment, and supplies. Today's speakers are Peter Stille, a Managing Director of Healthcare Performance Improvement at FORVIS, and Kevin Rash, who also is a Managing Director of Healthcare Performance Improvement with FORVIS. We've worked with FORVIS now for many years. They're valued friends to the Hospital Council. We have a tremendous turnout today, so we're looking forward to this presentation. Before I turn it over to Peter, please note this. We'll be glad to take your questions. If you would please type them in the question box or the chat box, we'll try to answer them at the end of the presentation. With that, ladies and gentlemen, I'm going to turn it over to Peter.
Thank you, Steve. Good afternoon, everyone. Good jam-packed agenda for you today. There's a lot to talk about. Wanted to start with going over some national trends and then going into and sharing some approaches that worked with helping reduce labor and contract labor expenses. And then turn it towards the non-labor side to round out that discussion, end with key takeaways and answer any questions from the group. So looking forward to a good discussion. Thanks for spending some time with us today. I think it'll be valuable.
All right, Pete, I'll take it from here. I'll make sure everybody can hear, and I think the screen is being seen. Pete, if you give me a thumbs up, I can see you. I know if you can hear me, everybody else, very good. It's good to be with you all, and we do appreciate your time. Our overall objectives, as Pete said, is just to make sure that you've got some key takeaways of what may be happening. Some of this may be confirmation of what you're feeling and seeing. Others may be new and create different thinking as you work through this. So just real quick, and I think Pete will do this when it comes back up for the non-labor. He and I work together, as stated, here at FORVIS. We've both been doing these types of things for well over 25, 30 years. Myself, I spent the first 25 years of my career inside industry as a clinician, then manager, and then executive leader. Briefly would describe myself as a recovering administrator turned trusted advisor or consultant. And what I want to make sure we kind of work through today is, you know, at any given time throughout your careers and what's happening in healthcare, headwinds can be used at any given time. Right now, there's a renewed focus, as you see here, on margin. We're spending a lot of time within organizations of any size, and this can be from critical access all the way up to, you know, multi-billion-dollar system, where we're really working through what's the focus for margin. You see here a few bullet points, and we just want to touch on these to probably confirm. You're seeing supply cost at an all-time high. This started and really increased, you know, in 2020 when the pandemic hit. Supplies became a big thing or bigger, and those supply chain executives were getting a new, renewed place at the table to help understand what was occurring within your organizations and how you would go about it. Those costs have not declined. If anything, they continue to increase. And the vendors are really trying to increase that for our organizations when it really isn't a complete need to increase those dollar amounts within there. We'll talk a little bit further later in this presentation. You've probably already heard a few things around revenue cycle, but those metrics continue to be a little bit, if not greatly, off track. It's interesting what we're seeing, I would say, in this area around revenue cycle. We're not here to speak today too much about revenue cycle, but we'd be remiss if we didn't bring that up as one of the headwinds that you're starting to see. The next bullet point, and the second to the last one, really, that remote workforce and the labor shortages. You're starting to see trends different than what you've ever experienced. And this creates a whole different culture for your organization. And how are you addressing that? And some of it could be through the contractors that you see in here, as well as are those benefit rates are starting to increase at too high of a pace than what you can afford. Inflation driving those non-supply areas, utilities, we'll speak a little bit further about that coming up. And then really, you're starting to see volumes return in certain key areas, but are they the right volumes that you are experiencing? And is that creating a margin compression within your organization? So really that gross margin is really what you're really looking for. And how is that kind of fitting into your organizational success and stability? Just a little graphic to kind of show you how things have started to change over the last 12 months. Really, hospitals and organizations in their operating margin index, negative, and you started to see a little bit of positive in March of 23, and just as in June, 1.4%. This is what you're starting to see. Is this what your organization is? The biggest piece that I would really have you kind of take away is your organization starting to see that positive incline. If not, you're really still in that compressed time and really need to start thinking about what are my actionable items that are going to help me get into that positive flow. And that's really the key that we wanted to bring forward in this particular slide. Six areas that are top of executives' minds when they start to think about margin improvement. We're going to speak a little more in depth about labor and non-labor. In that revenue cycle, I touched on it earlier. The big key here that we're starting to see is we're struggling to get our charges collected, properly documented, out the door. And as you know, late as January of this year, we were starting to see increased trends to where, hey, we're getting denials at an unprecedented, amount. What do we need to be doing there? My personal opinion on this is that the insurance companies had great, great financial increases in their performance through the pandemic, and they're trying to maintain that and really starting to try and get out the door and deny us as quick as we can. So we need to get the bills out the door as quick as we can so it can be denied once, so we can start fighting and working through it in that manner. I'm not a revenue cycle expert. I do work in margin improvement with a lot of organizations and teams that are really focusing in on this. It makes a big difference on that front end. And that's a lever that you can pull. Revenue integrity, clinical documentation, the CDI, but really what's your pricing strategy, things of that nature coming through. And I think later in your guys' lineup, as far as what are ideas, service line rationalization, where are you spending your time with your physicians and service lines, and then 340B, the compression that started to happen here with the drug companies and their denials and things that are having to kind of work through with you there. There's more to come. We're not here to speak about it, but we'd be remiss if we didn't briefly at least talk about it with you to say, hey, are these 6 things on top of mind? Now, I will tell you, American College of Healthcare Executives, when they do their annual study of CEOs, for the first time in 22 years, labor and staffing and pricing of labor and staffing has become #1 topic in mind that is occurring within organizations. So strategies around that are important. And I'll tell you, from a labor standpoint, you can't work on labor without understanding non-labor because of purchase services, that may be existing within your organization. And so Pete and I are excited to be presenting together today with you for this very reason around working with the labor, non-labor, purchase services, all of those pieces. So Pete, I see you came back on. Is there anything you want to say right here?
Yeah, I just want to add a plug that 340B and service line rationalization is another webinar coming up in a month or two for this group. So you will be hearing more about that from FORVIS to kind of round out this discussion.
Thanks, Pete. Okay. So want to spend time here in just what we would call the staffing and labor. And for me, since the late 90s, this has been a focus within the job I was holding as a physical therapist and then director, but really came to fruition in my organization when I really started in that administrative suite with multiple responsibilities. And that staffing and labor is very important in productivity. And I'm going to spend some time around pricing, the rebasing that's occurred over the past 2 to 3 years, as well as do we need to have a renewed focus on what I would consider the basic blocking and tackling of efficiencies by department within our organizations. And do we do comparatives with ourselves over the past 3 years, how we performed, what's changed in our technology within those, those departments, have our processes needed to change based on what our consumers are needing and what our talents are within these areas. So to make that a little bit more understandable, I'll give you a couple of key things here. So when we think about key performance metrics within labor, there are two that we like to use to kind of give an idea, where do we start? And you see labor ratio and paid hours per adjusted discharge on the left at the top, and then you see kind of a clip of what are the measures of median, better, and best. And then there's two examples right below just to kind of walk you through. So the Missouri Memorial Hospital, you'll see, has a net patient service revenue of about 60 million. So I'm pointing you kind of where I'm looking. And when you take into consideration their salaries, their contract labor, and their benefits, they're spending about 44 million, or about 75% of their net revenue, their net service patient revenue. It's not hard to understand that if you're spending 75% in that space, you don't have a lot of dollars left to do anything else. And that could be in physician initiatives, it can be in just in different key things that you want to do within your market. So when you think about the number of total FTEs, it's a little smaller at 400, and you look at their average salary per FTE, pretty much in line, what we would say. But when you look at this paid hours per adjusted discharge, it's at 110. We look at that, it's in between median and better. So it really starts to point us to say, what's happening up here? Well, 28% or $10 million is what they're spending in contract labor. Their initiatives need to be around efficiencies, retention, recruitment, those types of things within their organization. And so that's a quick key KPI that we would look at and want to work on with this particular organization. Go to a little bit larger of a facility. We've got about 230, 240 million in net patient service revenue. They're spending about 17% on contract labor, so they've got just as much. We'd like to see this, pre-pandemic, if you were watching your contract labor, those studies would show probably in the best operating, 2 to 3%. You're still going to have some contract labor within your organization, and defining that as purchase services, outsourced, those types of things are going to be in there. However, when you continue to look at then their paid hours per adjusted discharge are just really off the map. So there's a lot going on in this organization around data integrity, and what are they using to help make their decisions. So you want to make sure that your data that's bringing forward from your teams and your systems is telling you the right things, and it's very important in that particular space. We're going to talk a little bit about data integrity here in just a moment. This particular organization, what do they need to focus on? we would tell you first, we got to make sure this is way too far off the map. Something's wrong with their information. They can't make a valued decision there based on the information that they have. I would also kind of show you that when you start to look at what they're paying on the average for their per FTE and their benefits, this is a little bit off the map for somebody that might be in the Midwest to be paying on average 92 in salary. And then the benefits not too far off is 28%. We'd like to see that a little bit lower in both of these. And Peter will talk a little bit about that here when we get back into that non-labor. So takeaway here, what are two areas, labor ratio, paid adjusted, and then I'll bring your attention down here to kind of the asterisk below. If you've been in healthcare a long time, the FTEs per adjusted occupied bed, and you'll see the comment there, it's not necessarily operational, still important to your banks and bondholders. So you're going to see that metric out there. If we were just talking operationally and we were, making that recommendation, you've got to keep that going within your accounting and finance, and the C-suite needs to understand, especially if you've got, your loans and bonds. However, operationally, I'm not sure it tells you much any more than what labor ratio and paid hours per adjusted discharge would. What we want to take away from here is that it's a process, trying to get to that sustainability at the end. And when you're trying to enhance your productivity culture, there are many things that would come into account. We talked about the data. We want to make sure that you've got target expense management and revenue growth. And then you want to get to that sustainability where you're monitoring and you have actions emerging from those trends. I think we've moved away over the last 10 to 12 years of really a good focus in that productivity culture, training our managers and our leaders in understanding what is business and financial acumen. We take our best nurses. I'm a physical therapist. This is the story I'll tell you. I was a great physical therapist. I could treat spine and feet better than anybody else. And you guys would have to believe that because that's what I'm telling you. But then we take those people and we make them managers. Well, they didn't teach me anything in PT school about business and financial acumen. Heck, they didn't even tell me how to bill. I had to do that in my first job. And then when you start to try to be efficient, you got to start building that business and financial acumen. Some people can get it, some people can't. Think about that in nursing. Think about that in pharmacy, all those clinical spaces that it's not really necessarily bringing that teaching to it. I gained it by partnering up with some really good accounting and finance people. And then the pursuit of my fellowship in ACHE is a methodology that I use because I really focused on the accounting and finance. So I'm blessed to work with people like Peter, who is an accountant in background, right? And can make sure that what I'm showing around and bringing in is accurate and controllable. So that's the piece that I would tell you that really kind of works on this area of how do you get there in a productivity culture. It's very important to that business and financial acumen, which I believe is critical and missing from a lot of our folks that we put in management positions, sometimes even leadership within our organizations. Talk about data. And you saw kind of earlier in that Midwest hospital, we really started to kind of establish the data integrity. It's a non-negotiable, and you've got to have a source of truth. And unfortunately, in some organizations, you see that middle one that says EHR data. Well, there are a lot of organizations that continue to expand by purchasing different physician clinics or other hospitals, and they're not on the same electronic health record, or they need to bolt something on. And so now, what's your data repository? Where's that happening, and who is controlling that information? And is it the same when you're reporting it? And that's where you start to then have to kind of have it gear in with your ERP data. Is it secure? Is it valid? Is it timely? Is it accurate, to make sure? And that's critical in our organizations. The electronic health record, in my opinion, has advanced us greatly ahead in data, but are we using it in the right way to tell us how to make better decisions, whether it be from efficiencies, productivity, or even how we should be functioning with our information we're putting not only in front of our leadership, but in front of our boards. give you a quick workforce case study here. This is a rural hospital, and a lot of times we'll get maybe a phone call or a conversation. And when I started in this role 5 years ago, I really thought because of how critical access hospitals, sole community hospitals are reimbursed, that efficiencies wouldn't be a high measure for them. But as long as it's only a percentage, maybe it's 50 or 60% of their payers, there's still a place here to make sure that I'm right-sized for my commercial payers, all of those other necessary needs. So this FTE comparison is giving you an idea that this group here, this hospital, needed to right-size based on their volume and their payers. You had to keep both in mind. And for them, they had an annualized salary expense reduction of about $5.6 billion, or 7% improvement to the bottom line, that didn't affect the way the federal payers are hitting them. And so if you can do it in that particular space, you can do it further in sole communities, PPS, those types of places. This was a quick quick action plan that worked through with this particular hospital. So you look at their right sizing total paid FTEs at 453, they eventually got there. You can say, well, it's kind of skewed by the non-productive. Well, part of their strategy was they wanted to do it through attrition, but they needed to get into probably some early retirements and kind of work through their strategies. They didn't want to disrupt the community. So I'll use the word slash and dash. Been involved with it as an administrator. It doesn't work well because those people were doing something. And if we just cut those hours and those FTEs without working on what their processes and possible technology that can help them, what is it then that's going to be left off by that manager who doesn't have the business and financial acumen? They're going to stop doing something, and they're going to make a decision that they don't know much about, that then could further jeopardize revenue production, cost management within your own organization. And so getting that right education and training and knowledge is very important to kind of right size, if you may, as opposed to reduction in force. Now, there are times where you need to do that pretty quickly because of financials. Totally get it. Sometimes it's easier to do in larger organizations because we have, having been involved in a large $2 billion organization, you have some additional supports that you typically wouldn't have in a rural community hospital. One thing else that I put up there is when you think about your right sizing and you're really trying to get to the right pay structure, sometimes you need to drop off and look at your skill mix deeper. And that, to me, goes back to what we were doing in the late 90s, early 2000s, and trying to really address skill mix within our departments and make sure that we can keep our outcomes at a very high level, our patient experience, our coworker experience, our physician experience at a very high level, but make sure they have enough hands and bodies that are intelligent enough and trained appropriately to work through the needs of that particular department. So when you think about departmental responsibility and what are key things that a manager may need to be doing, this is just a quick snapshot of 5 things that we would say, hey, it's important for the business and financial acumen of your managers to know that, hey, can I look at my most recent 12 pay periods compared to what we established by budget to be my productive standard? In this particular case, it's hard to see the numbers, but this particular example is an emergency department. They're setting the standard at 2.9 productive hours per visit, and they're expecting volume at this level. And are they adjusting? This particular, they're adjusting to volume pretty good. Volume dropped off in this pay period. They tried to adjust, just couldn't get adjust. They didn't really adjust too much here. They should have been much further down than what they did. Not a lot of adjustment of FTEs in this particular organization. We see this in emergency departments and surgery more frequently, that they really don't adjust their FTEs based on volume. And what's that communication? Overtime as a percentage to see it quickly. And then what's that performance trend? This is just a nice, quick methodology of things that are key performance indicators, not at a high level, but more at a department level how do I know how I'm performing, and how am I being measured by my administration? What are the things that I should be looking at, working on in this particular space? What else does it tell you? You can see if you're working on that overtime, you measure it. You can start to see here in these particular organizations, their hours trending as well as their overtime. Once they started measuring it, it started to work its way down. It could be ghost hours or clock milkers is what I describe them at in overtime. Those are the people that are sitting at the clock to get that extra 6 minutes before and the extra 6, and you're now paying them 15 minutes extra per day, which adds up to, you know, multiple hours over the pay period, and then definitely gets into extreme hours over the lifetime of the year. So a nice trend when you start to measure it. What are the things that you can get out of it that are just very simple blocking and tackling? The next piece, this is the last slide here, and then Pete will take over from a non-labor. But when you're working with the nursing as a for example, and what's your daily census, how's your staffing overlay to that? These are pieces that this data will help them build a business and financial plan and bring that to you and say, this is what I'm looking to do. I can get to this point of efficiency, but we need some stabilization of our census, and how do we get there with that? So it's just nice other data to support your staffing trend. So not only is it labor related, but it then takes it down to that core within your departments. How are they using that information, and how is it overlaid? It's just not something that most of them know. It's an education and training that needs to occur. So with that, I'm going to pause, go on mute, and allow Pete to take over here from a non-labor, and what is he seeing that's happening out there.
Thank you, Kevin. So what we really wanted to do was share with you successful approaches in the market. You know, the supply chain is the other piece of the cost structure, majority of your spend, and it is vast and complex. The healthcare supply chain is actually the most complex supply chain in the world. And however, it can be, if you want to go to the next slide, Kevin. It can be a reliable generator. We've seen as little as 1%, as typically as high as 3%. Return on your margins as a percentage of net patient service revenue. And that typically happens if you've got the right approach. It's easy to get lost in the vastness of the supply chain. So you have to invest. You have to invest in analytics. You have to invest in benchmarking. You have to invest in time to make sure that you stay away from some of the pitfalls that can make it not the reliable return on investment that it can be, and that we've seen over my 32-year career doing this. And we want to share it with you is really a deep dive into the 80-20 top areas of opportunity. 1, med-surg supplies. 2, medical devices. 3, pharmaceuticals. And 4, benefits. And what we've listed here, just to round out the discussion, is the top 10 areas that we look at. But if we do look at those 4, that is 80% of what we typically focus on to get to that 2%. And they're kind of equally each at 20%. So on the next slide, we can kind of go over what that right approach is and really the pitfalls people have in terms of wanting to make sure that these return the investment that you want, and that they're successful. And so this is a graphic used in the market, kind of a think tank outcome of where the opportunities are in the supply chain. It's been around for years, but when I saw it, I thought that there was really a different experience that we had. So we took these numbers and really kind of repurposed it to what we thought. So we're in agreement at this first decision point about cost reduction in non-labor. We focus more on supply and services cost than logistics. In terms of bottom line impact, we found that it's just a better return on investment. It's at the next phase where we kind of take a right turn, literally. We'll go down to cost reduction and favor that, and take another right turn down to negotiations. And in negotiations, really, I've heard this for decades, that there's no additional savings available in negotiations. You have to standardize, you have to focus on utilization. And those are great. But time and time again, we see that from our perspective that we're not done focusing on price. We're not done maximizing on how we use our GPO. We're not done negotiating with our vendors on a direct basis to make sure that we're getting the value that we need out of these services, even in this inflationary environment. So those are the two pitfalls to kind of watch out for, and kind of an idea of where we start with negotiations, we'll get to the rest, but we really find most of our impact with the lower change, higher return areas that delivers. On the next slide, we talk about, okay, so if there's opportunity in price, where does that come from and how does that fit in with my GPO strategy? And it's a great question. The GPOs play a vital, important strategic role in management of your supply chain expenses. And maximizing their value is one of the things that you need to do. We'll get into that. But if we think about how they fit into the overall structure, it is not covering everything in non-labor. Here, this example, this client that we had, smaller client, 100-bed hospital in Missouri, they only had 20% of their non-labor costs that were covered by the GPO. Now, we're seeing that tick higher and higher, and we're seeing 35%, 40% with some better performers. But still, the majority of your cost structure is not covered by a GPO contract, and it needs coverage with a contract, typically if it's a high cost expense. And so you have three strategies at that point. One, and most often, we kind of break out in this bottom section here, that you can add a direct contract to help manage those things and make sure that that's optimized. Two, you have a GPO contract, but there's actually ways to, even within that contract, optimize those relationships and those prices with those suppliers. I'll give an example of a reference lab. There is pricing that's been negotiated with all the major reference labs for all the major GPOs. However, there isn't one list of prices for the 20,000 tests that you can buy from Quest or from LabCorp. And there are guidelines that are used, and there is a local customization that every one of these companies is allowed to do in order to make that the right fit for that particular test mix, that for the right volumes, for the right partnerships, and kind of give you an example of what additionally is available for you there. And in the minority of cases, we will look at something. There may be a PPI contract with a GPO that we might think or find out that we can do better on through benchmarking. Might indicate that we're above the high in the marketplace or the average in the marketplace, and we think that we deserve better pricing. And so we'll take things into our own hands. But interesting point here is that I've done this for 32 years and still not sick of it. Still challenge me every day. It's just so many different areas to learn and to try to master. But we've always been able to get an increase in GPO business through this process, because that is the number one easiest way to go to make sure that investment is optimized. So then if you believe that pricing is available, and right now we're setting the baseline before we get to our approaches. On the next slide, we talk about some of the things that kind of gets in our way from a local perspective, which is, hey, I'm only one hospital. I don't have the leverage of a major GPO with 1,000 hospitals that they're negotiating for, and that's true. However, in some cases, information, local dynamics, really, you'd be surprised at what the effect can have, and we're going to kind of illustrate that here. So the one thing that I will agree with that really isn't a myth is that I don't have the resources to generate these savings on my own. I've yet to see an organization that's overinvested in the supply chain. But the good news here is that if you see some success in investments that you make, you can replicate that and kind of redefine your strategy of where you want to go through supply chain and make it a value generator for your organization, a competitive advantage, like some systems have. And many of you may be seeing that value. Again, with the right approach, a consistent return on investment year over year. And so the example here is a little more depth on what you can do at the local level and how this can work in collaboration with your GPO. A few years ago, small organization spending $100,000 in office supplies, they had an overall global discount for their catalog before they got to this hot list item of what was told to us is 45 to 50% average based on a matrix of pricing that nobody could really explain very well. When we did the audit, we found out the weighted average was more like 35, 33% off of list price. And we did the benchmarking to show that 45% was actually more achievable and probably achievable for this organization. So we went to bid, and the incumbent participated, and the incumbent, found within their GPO the flexibility to be able to move pricing around in certain product categories to get us to that 45% goal. What's interesting is if you see, and this is a kind of another point that I make for other presentations that I give, is that this little small organization, $100,000 in office supply spend, went from 35% to 45%. Didn't change a thing. Put in some good controls. You'd be surprised how hard it is to control office supplies prices out there, guys. Even beyond paper. And they got to 45%, but and that's in the orange there in the first column. If you look at the blue column under $1 million, that's the fourth one over, that's $1 million spent in office supplies. So that little organization was able to get the same discounts as most $1 million spent organizations out there. Now we've dealt with those $1 million organization expense as well, and we have been able to increase those rates too. That goes orange. And what you see there is a pretty consistent delta with good negotiations and fact-based negotiations at a local level. But it's interesting to kind of see that you can make up ground of having a 10 times disadvantage on spend with good negotiations, a good approach in cost reduction and non-labor. And do that in partnership with your GPO. So now that we've kind of talked about things that is pricing worthwhile to be still talking about? Do I have the ability, the leverage to do pricing on my own? What else is out there? Let's talk about where that gets impacted the most. So one of the approaches that we do is we work typically closely with the GPOs to optimize the arrangements. Sometimes there is a competitive bid that the client wants us to do. But typically we can work with, and this is $2.5 million by just work with an incumbent GPO to bring forward additional savings for an organization the size of $1 billion in net revenues. And I wanted to illustrate two ways that we got there, and really they're the two key drivers. One, you'll see in the bottom left a graph that shows that their rebates, their share backs that they got were $1 million a year, which is great. $1 million is huge, wonderful. Let's not lose that. However, we showed them the organizations their size, depending on the GPO you're with, were anywhere from 1.5 to $2 million. And there are some best practices where they're getting pretty high. There's been some cases, and some of you may have seen some of these cases where they're getting more than 100% share backs to just buy the business because they wanted the volumes for strategic reasons. But here, we took them basically from like a 25% share back to share back in the 40s, and right about the average of the market. But for them, that was significant. That meant $700,000 in additional monies for them on an annual basis. In addition to that, in the graph next to it, we're doing an analysis of their pricing, and there's 100,000 different SKUs that go through the organization, and most of those SKUs are manual. So it's really hard to get your arms around it. And visibility, again, is one of the biggest challenges here. But you do have a PO, and that PO you can do analytics on, and many of you use analytics for a GPO. But one interesting thing to look at there is the drill downs are great, but overall, what is your percentage weighted average price compared to the average in the market, compared to the best quartile in the market, and where should your goal be, and how do people get there? Maybe for you, you've got a case mix adjustment or philosophy where you and your doctors can't get there. But those are the questions to answer in terms of really figuring out what you want your target to be. And what we did here was we dumped all of their PO, I think it was 60,000 lines, into our database. We have a IntelliSource database that we use. It's proprietary, and matched 70% of those items and showed that they were 9.4% above the market average. Whereas the best practices get 5 to 10% better than the market average. That's a huge swing for a lot of commodity products. And what we did was work with the GPO and drill down into those categories that were, in that 10%, 15%, 20% above benchmark range, and try to identify a strategy to reduce that. And for the most part, it was no change. It was, hey, we have a price tier that we're registered for, but we qualify for a better one, and we just haven't picked up on that because everything's moving so fast in healthcare. Or there is a small standardization that we can make, and we didn't realize that was costing us being able to get 15% better pricing in this category, and this is not so sensitive, and we'll do it, or we'll do a trial and see what happens. In some cases, we will then also look at the competitiveness of that price and do a competitive review and see where that ends up. Between those two strategies, it's really how within your same GPO relationship you get those types of savings, and if you challenge it competitively, it can sometimes be more. And I would say when you do bid it out, for the vast majority of the time, you're still staying with the incumbent. But it's good to know your options sometimes. The last area we'll talk about here with supplies and medical devices is physician preference items. And we've got an example here of spine. Consistently, since 1992, when I've been doing this, it's been double-digit savings, 15%. It even goes up to 35%. And you can see, some of you can see the percentage there, wide range. The Kaifon, in this case, not well negotiated in the market in general, kind of a monopolistic product. But you look at some of those plates and you see 45% variance to the average price. And when you look at the whole population, you get a sense that there's better pricing available for us. And so now let's go negotiate with the supplier. Let's go talk with the doctors to make sure that they're okay with that, understand our efforts. If there's willingness to do a competitive review, maybe look at capitation options to help us with utilization here, because spine is the wild, wild west still in healthcare supply chain management. So maybe one last comment here, key insight. Again, we don't get all that information without investment in analytics and investment in how to use those analytics, both in terms of setting our goals and equipping our people to be able to utilize those effectively against vendors who are very skilled and trained in negotiations. The next slide is regarding pharmacy. And I just want to make 2 points in pharmacy. One, there is a high return, low change option out there right now that's kind of emerged in the past couple of years. Many of you may have heard of it or doing it. There are some organizations that are better at getting results than others in terms of providing that in the market. I just lost my place. And what this is when there is alternatives, when there is PBM rebates available, and you're a self-pay organization, you get those rebates. And you get them because you're setting the formulary, the manufacturer wants to reward high market share. They also want to reward getting that claims data from you so they can use that referral information to inform how their product's being used and for that next product they have in development. When the claim is paid by insurance on the outpatient side, the insurers get that PBM rebate. When it's on the inpatient side, traditionally no one gets it. So a few years ago, there's been several companies that, on a contingency, have put together basically a dummy claim bill that gets all the information to the manufacturers that they are willing to pay for. And again, for an organization the size of $1 billion in net patient service revenues, that's $2 million or more in terms of net financial benefit, really just for exchanging data. The other thing I just need to mention, because in pharmacy, it's just the bread and butter of good supply chain management, and the pharmacy does things, frankly, better than the supply chain side for different reasons and philosophies. But here, Sugamidex, the second line down, is an example of formulary management where you've got a high-cost drug. It's a reversal agent to get people out of anesthesia. It costs $100 a dose. Before there was Sugamidex, there was neostigmine at $10 a dose and glycopyrrolate at $5 a dose. Bridion has some advantages in terms of operational efficiencies. They've got some advantages in terms of certain populations, not having to give the drug twice, etc. But if you sit down and have a discussion with your providers about A, the costs, and B, the populations that the studies show where this is increasing patient outcomes and where it's not, then they can think about, and really we ask them to bring back an algorithm to tell us how they want to use this and what restrictions that they would recommend that we make, and trial it and see how that goes. We've had success, very high success the past 3 years, reducing that anywhere from 20 to 50%. And by the way, in the market, there's no standard for this. Some of our clients use 0%, some use 100. So really medicine is really split on exactly what the need is to pay 10 times more for the Sugamidex than for what was traditionally working 10 years ago. A couple last areas for non-labor and approaches that have worked. Clinical variance, before we leave like the costs and move on to more purchase services, wanted to talk about this. This is a good example of really a utilization area that works. It actually is quite a lot of investment, but we've seen the organizations that have been committed to doing this, it be successful and it not be really relationship building with the surgeons and not relationship reducing. And so we've all seen versions of this. How we do it, we lay it out and have conversations with the doctors. We have the detail to show what the differences are between their usage and the lowest usage out there in our study, and ask them to consider trialing, given clinical outcome evidence and readmissions and infection rates, new ways to practice. And typically we'll see double-digit reductions. In this case, we're referring to a 58% goal we saw recently for a very committed client. It's very interesting to see that it's a supplies choice, different closure devices, different energy, advanced energy is being used. You've got one surgeon that orders a radiology test, the other doesn't. You've got lab tests that are ordered that others don't. You've got pharmaceuticals and antibiotics that are being used differently. And we did this for Lab Chole on purpose because in this, it's a very standard procedure. If you can eliminate some of the ones that came through ER, it's kind of as generic as you get from a procedure perspective. And to see all of this variance is really eye-opening for the administrators and then for the doctors when you show it to them. And then let's make one last point that when you do show this to them, they always want to hope that they're at the lower end of the range, so we do make sure that no one actually sees their names and can pick it out. But Kevin did this, his previous job overseeing the OR. He'll ask the physicians which bar they think they are. And then when they point to the ones that they actually are, typically it's the higher cost, and they want to be the one that they pointed to first. And how do we get there now? Very competitive, just taking advantage of that. But this is sort of on volume. So we should see a trend down with the more volume and the more experienced these surgeons are, and we just don't. And we've looked at it different ways, and there is no driver that we can tell is the reason why that would explain this variance. It's not outcomes, it's not age of the physician, it's not volume, it's just random as far as we've been able to identify it from our analytics. And so because of that, there's a lot of success we've had with reducing this and engaging them in a collaborative way. One last major area, benefits. This has been an area that has been very impactful recently, and I really just wanted to focus on the main area, PBMs. PBMs for an organization size, again, $1 billion. We have been successful in raising the rebates recently, 84%. And that increase is worth about $4 million for organizations of that size, that 84%. And so I will share with you that if you're not in these ranges, you're not getting the rebates that you need and you should have. I'll also tell you that this needs to be bid out every year, and I'm advising clients now not to sign multiple year contracts that you can't get out of because rebates are going through the roof. There's different changes in brands, there's different games people are playing. Industry is becoming a little bit more competitive. But if you look down here at the specialty brand, we have a $2,000 to $3,000 range. But just a few months ago, we got a client's marketing back, and several of the PBMs came back with specialty brands for $4,000. So it just shows you, just how fast this is changing. This presentation was done 2 months ago for another organization, and it's already outdated. So bid more in this category. And then lastly, I kind of wanted to show you that even though we've walked through all of these 4 major drivers, we have really experience with different organizations differently, and because it's not a cookie cutter. We need to come in there, we need to do our analytics to quickly get our arms around where the opportunities are, prioritize those, rank them in terms of pain versus gain, return on investment, and cultural readiness, and go after it. In the top right corner, that organization, they really hit it out of the park with purchase services. Part of it was they had a consultant in us focused more on PPI a few years before us, but information systems, biomed, dietary, EBS, these are all areas that were really overhauled and delivered very big savings for a mid-sized organization in the Midwest. The other, much different outcome. They saw a lot of benefit in benefits and in service line analytics, similar to the clinical variance that you saw, as well as program decisions. And then the other two, small community hospital, they did not want to deal with their GPO. So for them, it was a classic work with surgery and PPI and getting benefits in pharmacy. And the last area is the one that we're currently working on. This is a 14 hospital IDN in the Southeast, and they're on a pace for even above $30 million right now. 340B was a big driver for them. Asset relifing was a big driver. They did want to tackle GPO and head office to maintain their incumbent. And they were working on something that we hadn't talked about yet, and I just want to throw out there. There are some low capital energy efficiency options out there with 6-month paybacks that we're consistently talking with clients about that have got proven references and installed base in healthcare. One of them is a valve that attaches to your water pipe, and before it gets to the meter, it will take the air out of the water. And so air in healthcare is tracked about 22% reduction. And so the amount of water that goes through your meter is reduced by that much, and therefore your bill. In addition, some of these companies have leak management technology and Internet of Things that can predict or at least show changes in water pressure to help you manage some of the leaks prior to them actually becoming leaks, and repair that pipe before there is an actual event to repair. So that is my overview of non-labor cost reduction. I know that we've got some takeaways here, and I'll turn it back to Kevin.
4 areas here, key takeaways, don't necessarily need to read to you, but if you think about how you are looking at those margin pressures, what are those opportunities? We would be remiss if you didn't think about that revenue generation. That's a lever to pull, but are you doing it in the right place? So your service line, components that are out there. What levers are you pulling for your cost management and your GPO? The GPO will not address all, or possibly the right ones, and Peter did a great job of walking you through what are some things that you want to consider when working with that GPO, and where do you need help? I popped in there as Peter first started talking about the PPI. You might have seen me turn my camera on, and it was, hey, I used to think I was doing a great job with my negotiations, not only with my GPO and my PPI. And, you know, when I would get a 3% or 4% savings, we were high-fiving in the C-suite. Not until I really started having interactions with Peter, for example, did you start seeing these double digits and really that IntelliSource benchmarking that he has, and clients are really starting to experience this. And for me, it's a really cool thing, and it's one of those things I wish I knew then what I know now, and working with folks like Peter and making sure to get outside of my own four walls and hearing these things. So we do appreciate your participation today. The last two in here, that last one on there, that purchase services and agency staffing, you got to be considering that when you're looking at your overall efficiency and your overall cost structure. And that last piece there, new normal for you, right? It must be understood, planned, and managed. So with that, I believe we can go to, are you ready to start? And what questions do you have?
This is Steve. We do have a question or two, and here is what the person asked. They just read an article yesterday regarding United Healthcare removing authorizations on certain spine procedures. Would that translate to more volume, you think? And if so, is there a significant need for more supplies, and should this prompt a renegotiation for better rates? They just wanted your opinion.
Yeah, great question. I'm not familiar with this development. However, spine is one of the categories I specialize in. And for decades, the industry has been worried about a reduction of fusions because 50%, according to the experts and manufacturers and doctors that attend these conferences, of these fusions that they perform are not necessary. So in terms of what it means for the organization, I believe that your instinct is correct, that you get your arms around what you project that to mean for your organization, and whether it's a huge increase or there's a question about what it's going to happen to your program. The vendors are nervous about it, and it is going to be a lever for you to use in your negotiations. And I would use that as a springboard to approach what, sometimes these medical device manufacturers are just too comfortable in their positions, and the relationships they have with the doctors, and they're likely to switch. And I think this is something that can both be a potential increase with total volume, potential decrease for them if someone else comes to the table wanting that, potential decrease if it's a challenge to the volume, as well as justification for you to get tighter with your partners to want to work close with them in a changing environment.
Yeah, the only thing I'd add.
Okay, go ahead.
Yeah, the only thing I'd add to it, I'm not familiar with the article, but having been involved, 10 years ago with setting up a destination medicine, and you think about those folks and really spine and totals being in that destination medicine and the efficacy that Peter talked about, I'd be interested to read the article and further add to that. That's all I wanted to add to it. Thanks, Steve.
By the way, just so people know, a couple of people have asked, we're going to share the slides, and I think Chris is going to send those out today or tomorrow.
Yeah, they'll go out today.
Yeah. Here's another question. You've given us many good ideas and presented areas that we can look at. What do you recommend we focus on first?
Pete, you want me to start and you can add to it? I'll do that. So the way I look at it is understanding what the analytics and the data is showing us. So I always want to say, okay, what is the discovery? Where's the high value, low lift that is occurring within your organization? As Peter kind of showed those 4 examples, it's different for each organization based on maybe what they've been focusing on. Same thing is true with labor, not just non-labor, but where is the key areas that variance is occurring and what can be converted into that opportunity from efficiency pricing or our recruitment. So I always say, where do you start? I think you got to start by a rapid assessment of the labor, non-labor areas. Pete?
I agree. Invest in analytics, or take a second look at the analytics that you have, prioritize those, sort them, high return, lowest amount of effort and risk, and then begin with that one. So you can then justify adding more and more investment to this once you believe in it more. And as I was thinking about what area that is of everything that I'm doing right now, I think it's inpatient rebates. And I think if you go after something like that and show that, going to seminars, learning about these new options in the marketplace is worthwhile. Having these analytics and trying to learn how to use them, or challenging yourselves to make better use of them, can become then this effort that really will require organization to go after, and then you've got a pathway to success. But how do you eat the elephant one step at a time?
We have really two questions combined into one. What are you currently seeing for trends for agency staffing related to clinical areas? Second question, are there trends for non-clinical staffing you're seeing through agency?
I'll start. Pete may have some add here, but from a clinical staffing, the pandemic really exploded in that manner for major areas of like RNs, respiratory. Those are the areas that we were seeing explode. Those are starting to trend down. I would also tell you what we're seeing in trends is the actual pricing of those agency staffing. So if you haven't had opportunity to really look at those contracts and renegotiate those pricing, that's what we're starting to see and really help clients work through in that manner. From a non-clinical, what we're seeing there in agency is the outsourcing of certain key areas. It could be, in your coding. We're seeing that. We're also seeing some outsourcing in dietary and or environmental services. Those would be the three key areas that I'm seeing within the client work across the country. Pete, anything else there?
Establishing your own temp agencies, and managing the staff ratio so you don't need them. Coming up with, I was just talking to a CEO yesterday that they had so many perks for the internal people to staff low volume weekend and nights that they're making $250,000 a year, some of these nurses. So you can get crazy with the incentives to get your current people to fill those positions. But those are the two main strategies I've seen.
The final question we've got is, it's hard to visualize accomplishing some of these savings outside of working in your current GPO relationship. Many organizations have benefited and made progress with their GPO help. Can you say that this strategy can be successful with active and committed GPO relationships?
Yes. So there's a lot of different ways to structure it. Our strong preference is to collaborate with the GPO. And you can essentially get a list of what the GPO wants to offer that they're not offering today, a list of what they are offering, or can we make better use of, and a list of the items that the consultant has that they've identified. All get together and figure out how you want to accomplish it together as a group and really maximize the impact. We want what's best for the organization. So if the GPO is going to be the best solution there, we would typically help project manage that to make sure that gets done well, done as quickly as possible.
Chris, I don't see any other questions pending, so all I can say is this has been extremely helpful. And Peter and Kevin, we can't thank you enough for a job well done.